Hi, I'm Conrad Fisher, and welcome to the neurology section of Step 2 CK. This DVD is the most modern, most advanced thing that we can do to prepare you for the USMLE examination. Each section can be changed, updated, upgraded, made modern as each change in medicine occurs. We're going to be starting with diseases of the spinal cord. The first part of this is to say, how do we know when someone has spinal cord compression? Lots of people can have back pain. Lots of people can have back pain. So the patient at the beginning of your case of this section, when it's described as a 63-year-old man with back pain, lots of people have back pain. 2/3 of the population has major back pain that's almost incapacitating at some point in their life. But what they don't have is they don't have the big difference, which is spinal tenderness. They don't have tenderness. That is the biggest difference, okay? They don't have spinal cord tenderness. When you have spinal cord tenderness, tenderness implies the possibility of compression. How do I know that this is not simply lower muscular, lower back spasm? And how do I know it's not simply a little disc or a little sciatica? Because there is tenderness in cord compression. If it's simply low back pain, the answer is non-steroidals and stretch. Back pain, non-steroidals and stretch. But tenderness means compression. Now, the other thing that tells you that you have something as a super emergency, hyperactive deep tendon reflexes. When you block upper motor neuron input, the reflex arc of the lower motor neurons has a hyperreflexia because there's no inhibition from above. In addition, you have a sensory level. In other words, T4, the fourth thoracic vertebra, is here at the level of the nipples. The umbilicus is T10. You could have a sensory level, like your body has been cut with a knife and you feel nothing below it, or you feel less below it. A sensory level, it's cut and you feel less below it. Hyperreflexia, sensory level. Incontinence sometimes, but the most important thing to tell you, compression, is spine tenderness. 63-year-old man. Let's see, remember this first slide, comes with a neurological emergency. Can be cancer, can be abscess, can be an epidural hematoma. What if you had back trauma and you bled into your spine? Epidural hematoma. How will you know what the most likely diagnosis is? Well, they'll have to tell you. The person has a history of cancer. The person has a history of trauma. The person has a fever. If you throw in fever with this, then this all of a sudden becomes that you are obsessing. It's a fever, you're obsessing. So we have cancer, we have epidural abscess, we have hematoma. How do we know that this is trauma and abscess? You throw in trauma and you know that it's a hematoma. And other than that, they'll give you a history of cancer. 63-year-old guy comes with back pain, back tenderness. You think there's cord compression, sensory level, DTRs, increased incontinence. What is the next best step in the management of this patient? MRI, biopsy, CT myelogram, X-ray, steroids. X-ray, CT myelogram, MRI, biopsy, steroids. What is the next best step? Now, when the questions say step, action, do, or management, step, action, do, or management, step, action, do, or management, is it a test or is it a treatment? Can be either one. Either one. Step, action, do, or management, step, action, do, or management. Can be either one. So when it says back pain, tenderness, compression, hyperactive reflexes, sensory level, it goes like this. I have a tattoo that says cancer impinging here, compression here. So if you have all this clear presentation, this is such a clear presentation that when it says what is your next step, the answer should be steroids. The steroids decrease the inflammation. The steroids decrease the inflammation around the compression. The steroids decrease the inflammation around the compression and decrease the symptoms of a compression. You see, tender, Hyperactive, level, pain, clear, steroids. What if the question say, what's the best initial test? Then the answer is X-ray is the best initial test. MRI is more accurate than that. And biopsy is more accurate than that. When do you answer the CT myelogram? When is a CT myelogram the answer? The answer is only one reason to put a lumbar needle in me and pour in contrast and hang me upside down and watch the contrast grow. Flow. And the only reason to do that CT myelogram is if you can't get an MRI. A CT myelogram is like an IVP in the sense that the only time to get an IVP if there's no other choice. The only time to get a bone scan in osteomyelitis is if you can't get an MRI. The only time to get a CT myelogram is if you can't get an MRI. The CT myelogram is dead. Pasado. Reporting to you from Arlington National Cemetery, the CT myelogram has been laid to rest in the tomb of crappy tests from the past. Thing was torture. Torture, man. CT myelogram, spinal needle hanging you upside down, dripping contrast, forget it. MRI is better. Let's look at the next slide. Now, spinal cord compression. The sensory disturbance is because the neuromuscular, sensory transmission is blocked on its way up. It's blocked on its way up. If you have a spinal cord, if we look at this is brain, spinal cord. You like that, Dr. Fisher's spinal cord? If you have pain and temperature comes in, it crosses right away at the cord and comes up. Those pain and temperature fibers cross right away. Now, if you are compressed, it means that you can't feel anything below you. It means you can't feel the contralateral side. You can't feel the contralateral side. So here, if we look at a cross-section of the spinal cord, I'm sorry, I'm more autistic than artistic. The pain and temperature fibers decussate at the level of the cord near the center of the cord. The pain and temperature fibers. Pain and temperature fibers decussate at the level of the cord right there in the center. And they go up, pain and temperature, on the opposite side. On the opposite side. Now, position and vibratory sense is different. Position and vibratory sense is all posterior column. Position and vibratory sense is different. Position and vibratory sense goes in on one side. Position and vibratory sense, it goes up on the ipsilateral side and crosses at the brainstem. Okay? Vibratory sense goes up on the ipsilateral side, up on the ipsi, whereas pain and temperature goes up on the contralateral side. Goes up on the contralateral side. That's why in Brown-Séquard, when the cord's been cut, that's why in Brown-Séquard, when the cord has been cut, in Brown-Séquard syndrome, that's why in a Brown-Séquard syndrome, if you cut the cord on one side, you are cutting the contralateral pain and temperature and the ipsilateral vibration and position. The contralateral pain and temperature, and the ipsilateral vibration and position, because the ipsilateral goes up in pain and temperature, position and vibratory, and the contralateral in terms of pain and temperature. Cord compression. You get weakness because you're compressing the motor neurons coming down. You get sphincter dysfunction because you're inhibiting the reflex arc. You get pain in the back because getting your spinal cord stepped on hurts. You get hyperreflexia because you're inhibiting, here you get hyperreflexia, you're inhibiting the upper motor neuron input. Now, the treatment for spinal cord compression, high-dose dexamethasone. Well, why dexamethasone? Dexamethasone, why DEXA? What does dexamethasone have that fludrocortisone doesn't have as much, for instance? Dexamethasone has the highest glucocorticoid activity. Glucocorticoid means anti-inflammatory. Mineralocorticoid means it acts like aldosterone. Glucocorticoid means it has anti-inflammatory activity. Mineralocorticoid means it acts like aldosterone. So the steroid you use is dexamethasone. Now, back down here to our treatments. You'll notice here where it says tumors, we use radiotherapy. That's why, except for steroids, you have to have a biopsy, an MRI and a biopsy before you can do further therapy. Other than that, you don't know if it's cancer. If you don't know it's cancer, you might be radiating an abscess. So unless you have a biopsy, you don't do radiation therapy. Now, this next slide is an image of cord compression. This is showing you a person who here at this level has a compression of the cord. You see this white stuff here? That's cerebral spinal fluid. That white stuff, that's cerebral spinal fluid. You notice that there's no white stuff after a while. No white stuff on either side. The white stuff coming down, the white stuff coming up on either side is the cerebral spinal fluid. In the center is the cord. Here there's the compression. Why? Because what's happening is that the spinal cord is being compressed and the cerebrospinal fluid is being squeezed out. The best initial test would have been an X-ray. We already have an MRI. The most accurate test is a biopsy. The next best step in management is steroids. And then this has been decompressed because they've removed a lot of the vertebra, and you see the white stuff goes all the way through, white stuff will go all the way through. That's the cerebrospinal fluid. That's the cerebrospinal fluid. That's the cerebrospinal fluid. And that is cord compression. What's the difference between cord compression and other causes of back pain? Cord compression gives back tenderness. If there's a fever, think of an abscess. If there's trauma, think of an epidural. If there's clear hyperreflexia, loss of sensation, sphincter dysfunction, go straight to steroids.